Welcome to Quality, where we are exploring quality in emergency care. This is your host, Arjun Venkatesh. Today's episode is the next in our series from our Emergency Quality Network Venous Thromboembolism Initiative. We've had several episodes digging into various aspects of VTE care, and today's special guest is Dr. Bo Stubblefield, who's an emergency physician. He's a national expert on VTE, and he's coming to us as faculty from Vanderbilt University Medical Center in Nashville, Tennessee. We're excited to have you, Bo. Welcome to the show.
Thanks, Arjun. Thanks for having me.
Today, I wanted us to dig into the thing you're really expert on and a place where I think we've learned in some of the earlier episodes, there's a lot of improvement for trying to take science to the bedside, really get it applied on evidence-based medicine and do a better job in VTE care, and that's anticoagulation. When I graduated residency, this was fairly simple, which was every PE got admitted to the hospital on heparin. The big question was whether or not occasionally some patients could get low molecular weight heparin. If I remember right, there was a trial in cancer patients, and so we would try to treat cancer patients differently than other patients. There was no DOACs. And more importantly, because of Coumadin, there'd be a bunch of debate around bridging and things like that. But I remember at the time thinking the vast majority of what we did was based on story and anecdote and sort of lab-based evidence, but not real clinical research. And we've come a long way in a decade, but it feels like practice hasn't caught up. If you see a standard PE in the ED today, where should we be going first when it comes to initial anticoagulation treatment?
Yeah, you make a lot of good points. Dating back to the 1940s, anticoagulation has really been the foundation of acute venous thromboembolism treatment. And it was first in the form, as you mentioned, of unfractionated heparin, which rapidly expanded to low molecular weight. And then with the advent of the DOACs, it's facilitated outpatient treatment over the last decade. And it's important because, therapeutic anticoagulation and achieving and therapeutic APTT within the first 24 hours has been shown to be associated not just with lower in-hospital mortality, but lower 30-day mortality. So that has implications in capturing PE patients who are both admitted to the hospital and discharged from the ED. And my general approach here is we start with the classification of pulmonary embolism. And for that, we use the ESC 2019 guidelines that basically puts PE into three buckets, really four buckets, but the intermediate is split. And the buckets are low risk, intermediate, and that's intermediate, lower, high, and then high risk. The low risk category are kind of across the board stratified by, the hemodynamic stability of the patient, the clinical parameters like the S-PESI or PESI, and then RV function based upon imaging and cardiac troponin levels. So if you're low risk, you're hemodynamically stable, you have a S-PESI is 0, you've got no right heart strain by biomarkers or imaging, whether that be CT or ultrasound, and you may be a good candidate for outpatient therapy. And generally, the recommendation is, these folks, as long as they have reasonable renal function and no hepatic dysfunction, they can probably go home on a DOAC. They have good follow-up and you think they're going to take their medicines. A DOAC is a nice, reasonable choice. And what we're seeing mostly prescribed in both my department and other folks who I interact with, they're giving either apixaban or rivaroxaban. And we can talk about some of the nuances of that prescription later if you like.
Well, let me ask you one question that's sort of not even nuanced between those two. But if you got that low-risk patient and you can treat them with a DOAC, let's get at what I think is probably one of the myths out there, which is, can you just start them, give them the first pill in the ED and discharge and have them pick up a prescription? Or is there bridging with these medicines? Are there any special considerations in that first 24 to 48 hours? Or are we just overcomplicating it?
So each of these DOACs underwent phase 3 trials, which showed equivalent rates of VTE and VTA-related death in terms of efficacy when compared to warfarin. So they seem to be just as good as anticoagulating when compared to warfarin. But when you look at safety, that is major bleeding or clinically relevant non-major bleeding, each of the 4 available DOACs when compared to Coumadin were actually better. The DOACs, rivaroxaban, apixaban, don't require any kind of parenteral lead-in when administering them, but something like dabigatran or Pradaxa would require some sort of parenteral initial anticoagulation. So generally what we're seeing is more of just give the pill in the ED, give them a prescription, let them go home. And there's some nuances to how they take the medicines and so forth.
Let's talk about that next group then, the intermediate folks. My guess is once you get into that intermediate high group, now we're starting to talk about, should this be an unfractionated heparin drip? Should it be a low molecular weight heparin? Or is there also, are we talking about DOACs in that group? It's just being admitted to the hospital because they're higher risk.
Yeah, generally with that group, we're talking about giving them either low molecular weight heparin or unfractionated heparin. And low molecular weight heparin overall has been shown to have more predictable pharmacokinetics and don't require any kind of routine monitoring. So a number of trials have demonstrated that the use of low molecular weight heparin results in better outcomes compared to unfractionated heparin, including a reduced risk of major hemorrhage.
It's a really important point. I'm going to say that again. So you're telling me that where the clinical research is, where the evidence is at, is that low molecular weight heparin would be a superior choice to unfractionated heparin.
Correct. As long as the patient is kind of within the bounds of a reasonable BMI without extremes of body weight and also having normal renal function, low molecular heparin should be your go-to choice for initial anticoagulation.
That's a big point for our listeners because we had Jeff Klein on Quality a few episodes ago, and he was talking about how here in the United States, our outcomes for PE, meaning mortality or heart failure, these other outcomes, haven't really budged much in the last decade. Versus in Europe, they've gotten much, much better. And one of the reasons he sort of hypothesized for this difference was that we're still in the US using a lot of unfractionated heparin, resulting in a lot of people being either under anticoagulated or undertreated, particularly in that early period. It's hard to manage, it's hard to track, hard to follow. We have a lot of patients moving between hospitals, one ED to another ED. Is that sort of where the bang for the buck is with low molecular weight heparin? It's that first 24 hours that we're getting predictability around?
Yeah, unfractionated heparin in contrast to low molecular weight heparin is known for these unpredictable pharmacokinetics due to kind of its variable half-life, its two-phased elimination, its extensive binding to plasma protein. So there's been some nice work showing that within the first 24 hours, only about a quarter of the patients are therapeutic on unfractionated heparin. And 50% are actually in the super therapeutic range.
Oh, so you can swing low or swing high.
Yeah, and really, only about a fifth of them are therapeutically anticoagulated when given unfractionated heparin.
Okay.
24 hours.
That's a big deal, right? So if I think for our listeners, if there's one thing I think they walk away from today with, it's, let's be smart about that first anticoagulation choice, particularly if it's heparin or low molecular weight heparins. You spoke a little bit about body weight being one of the nuances to think about. Renal function's a different one. What about sort of, outside of the clinical realm? I'm guessing there's a lot of docs we have listening to the episode today who are like, yeah, but, cardiology always tells me to use unfractionated heparin, or I hear from pulmonary we should do that because they might need to get a procedure or they might need to get reversed. How do you sort through all that part?
Right. So, protamine sulfate, it has been used for reversal in the past. And one of the big myths around protamine is that it can't be given for a low molecular weight heparin, and that's just simply not true. Protamine sulfate in itself has only been shown to be maybe at best 60% effective in reversing the anticoagulant.
Is that for low molecular or even for regular unfractionated heparin as well?
If my memory serves me, I think that's been shown for unfractionated heparin. I can't remember the exact reversal for low molecular weight.
Got it. So low molecular weight heparin is reversible. What about this whole procedure concern? Is there a difference when it comes to folks who are now increasingly doing either thrombectomies or catheter-directed lysis and other types of interventions for these PEs and DVTs?
Yeah, the other important point I like to leave people with is that only about 5% of patients with acute pulmonary embolism advance to have some sort of advanced procedure, whether that be a site-directed thrombolysis or a thrombectomy. And so preemptively giving them unfractionated heparin with the concern that they're going to go for the procedure is not really warranted. When you are talking to interventionalists, in my experience, there are kind of two groups. Many of them are still willing to take the patient for an advanced procedure, even if they've received low molecular weight heparin in the ED setting. So there's nothing precluding the interventionalist from actually taking the patient for advanced procedure, even if the patient had received low molecular weight heparin and had to proceed to some sort of advanced treatment.
Yeah, no, I think that's a big point because that's true in the PCI world. It's true in a variety of other procedures as well. And my guess is it's like a lot of things we do in acute care and hospital care is a tradition gets built. It doesn't have a lot of evidence around it, but sometimes those are the hardest ones to unwind and pull apart. Than the ones that are just sort of bad science, and new science helps us make a better decision in the future. Let's talk a little bit about some of the special cases out there because, I think everybody, it used to be, if you went back a decade, we used to have a quality measure, which we quickly retired, fortunately, that looked at the proportion of ED patients that got anticoagulated for a PE. And even when we went out national with this measure, we knew that there was not really a huge gap in emergency care. And within a couple of years, basically every ED in the country was at 100%. And so we got rid of that quality measure. But what it taught me, what I've been thinking about a lot of since, has been that, even as we have sort of figured out that we need to get everybody anticoagulated, we still have delays. And the delays are often in some of what I call the tough cases, the more challenging cases, the kinds of cases where sometimes you're talking to neurology, neurosurgery, oncology, OB, things like that. And so let's go through a couple of those and you can sort of help guide us how we should be thinking about them. Let's start with pregnant patients. So we know that there is, a small but real sort of increased venous thromboembolism risk during pregnancy. I think everybody has, developed their own institutional approach to imaging and how can we be radiation sparing? Is it going to be shielded CTs or VQs? And that will vary site to site. But if you are unfortunate enough to end up with a PE during pregnancy, how should we be thinking about anticoagulation in that group?
Diagnostic testing aside, patients in the postpartum period or in the later trimester periods, they have a 4 to 5 increased risk of having venous thromboembolism compared to non-pregnant patients. So with 80% of these being in the venous system. So there's certainly a higher risk in these patients. And per the ACOG guidelines, the preferred anticoagulant in pregnancy are heparin compounds. Neither unfractionated heparin nor low molecular weight heparin cross the placenta, and both are considered safe in pregnancy. And generally, what we'll do is put these patients on low molecular weight heparin once they're therapeutic low molecular heparin once they're diagnosed with their venous thromboembolism in pregnancy.
That's really helpful because I think it's straightforward, it's clean, and it's nice that there's that ACOG guideline out there as well to sort of go off of. What about patients with active cancer? Has it changed since I was a resident, or is it still low molecular weight heparin?
Yeah, we've used low molecular weight heparin for the last decade in cancer patients, and this was based upon the Agnes Lee New England Journal 2003 paper, which showed that there was a decreased risk in recurrent VTE in patients who were randomized to the low molecular weight heparin group and compared to those in warfarin. And there was additionally some survival advantage in those patients with the low molecular weight group. But there's been some studies since. Most recently, there was a study in JAMA in 2023 looking at the comparative effectiveness of anticoagulants using claims data in cancer patients. And what they found that DOACs seem to have a lower risk of VTE recurrence and a lower risk of major bleeding, and with some improved mortality. But there's been some meta-analyses since that time that have shown that there was a slight increased risk of bleeding, specifically in the GI subgroup of patients with GI cancers. So the general recommendation is DOACs are a reasonable choice and compared to low molecular heparin in the overall cancer population, to be a little more vigilant in patients with GI cancers associated.
Got it. Very helpful. So one of the ones that pulls, I think, there's emergency physicians pulling their hair out about is the patient that's got a brain met and has an acute PE, hasn't had a hemorrhage before. And I guess even before we get to sort of what's the right anticoagulant, is there any science? Do we have any general recommendations on whether or not the PE should be treated?
Yeah, I think VTE in cancer has been shown to be the second most cause of mortality, secondary only to the cancer itself. So these VTEs need to be treated. And generally that happens in consultation with the patient's hematologist, oncologist, and how we want to go about treating that with the selection of anticoagulant. But generally these thromboses need to be treated.
That's helpful. That's helpful. Tell me about another one. We've been talking a bunch about how to treat everybody who needs anticoagulation. I've been hearing more and more out there, though, about, a lot of these are really subsegmental PEs, and there's some patients who get another CAT scan. You don't even see it a few weeks later. Is there, you think, any populations that are emerging where we could actually do no anticoagulation?
Yeah, there's some controversies that exist kind of in the field. And the first is, who needs anticoagulation? And in particular, the one that you mentioned, the population of patients diagnosed with subsegmental PE. So what's the risk of VTE recurrence in patients with subsegmental PE managed without anticoagulation? There's been some recent work on this by Gregory Legat, who published a prospective cohort in 2021 in Annals. And basically what they showed was that the recurrent rate of venous thromboembolism at a 90-day period as the primary outcome was found to be higher than the expected meaning that out of about 266 patients, they found that there were 8 patients, so cumulative incidence about 3.1%, where they had a recurrence of VT over a 90-day period. So there are current grade 2C guidelines from CHEST saying that you can consider surveillance in this particular population. But there's some real world evidence that suggests that maybe structured surveillance is only eligible in a small proportion of patients. And in reality, most patients are not going surveillance in clinical practice.
No, I think it's a good point because, the more and more we learn about venous thromboembolism, I think people need to start recognizing that these are not just like isolated episodic episodes where you just sort of have one, whether it be really small clot or one clot, and then just sort of the problem goes away. When we've had others on the podcast, one of the things they've talked about is one of the reasons that we sort of have not had some of the outcome improvements that we've wanted with PE and DVT is that we are so hung up on the idea of avoiding over-treatment with anticoagulation, and then more importantly about stopping anticoagulation. And that probably comes back from the warfarin days where it was really cumbersome and hard to tell people to go, get their PT checked every week and then be in and out of clinics and try to balance a job, everything else. And so that results in us really trying to aggressively turn off the anticoagulation in people who probably aren't just having a one-off illness, but are at risk of, more clots again in the future. And it's why I think recurrent VTEs and all these trials, do you think that world is changing? Like, are we rethinking who and when to stop anticoagulation with these newer drugs that are out there?
Certainly, this is really more of a question for the hematologist to really think about duration of anticoagulation and when do we stop, when do we start. But I think from the acute care setting, from the emergency setting, when we think about anticoagulation, we can even extrapolate this all the way back to diagnostic testing. When we think about who we're going to test for a PE, we should really risk stratify them in a formal way using a structured criteria like revised Geneva or Wells to determine if they are eligible to undergo D-dimer testing rather than rushing to imaging. Because as you said, some of these patients get scans and maybe one out of 2 radiologists might not agree that there's actually a subsegmental thrombus there on the CT scan. So these patients, are going to be anticoagulated, and there's risk with this anticoagulation. So you may end up finding incidental findings or clots or thrombus that are not particularly prominent or may not be there based upon whatever radiologist is reading the scan, and that comes with real risk. So this goes all the way back to kind of diagnostic decision-making in the acute setting of, who gets imaging right away and who can potentially be ruled out with a lab test that prevents further imaging that would find in maybe an incidental non-existent finding.
That's a good point. I mean, I'll flip you to the other side of it now, because I think you're right? Like there's going to be a lot of work from the hematologists around how long people should be anticoagulated for. What we see in the ED though, and I wonder how you think about this, is the patient who has had a prior clot and recently stopped anticoagulation. We get really worried if some AFib patient comes in and says, oh, I missed my last 2 doses of apixaban. How should we think about the patient who had a PE, was anticoagulated, came off anticoagulation a couple months ago, and is now in front of us with chest pain or shortness of breath?
Yeah, I would go back to, really formally risk stratifying that patient. Prior PE is certainly a risk factor for having an additional PE, but I think that risk factor is just one of many that goes in kind of our arsenal of thinking about how we work that patient up diagnostically. And then, moving forward, the DOACs have a pretty small half-life, meaning that generally, if you're going to have surgery the next day, that the surgeon will ask you to not take your DOAC that morning, basically. So after stopping a DOAC, you basically are not therapeutically anticoagulated after within 24 hours. So that's to be considered. But in terms of working them up or determining, how we look for this PE in the patient who comes in with AFib who hasn't taken his anticoagulant, how we work that up and how we decide to anticoagulate are things to consider.
Thanks. Yeah. I appreciate you running the gauntlet of my cases. I feel like we got to not only talk about the big things, we got to talk about how we need to really be thinking about using low molecular weight heparin more than unfractionated heparin when we have the choice and it fits the right patient. We talked about the fact, which I really appreciated, about this myth around that you can't reverse low molecular weight heparins. I always give every guest on the show the soapbox at the end. And so if there's one thing you want our listeners out there to know about anticoagulation or treating VTE, what do you want to share with them?
So I generally tell people the rule of fives when I'm talking about low molecular heparin versus unfractionated heparin. And the rule is that only about a fifth of patients who are treated with unfractionated heparin are therapeutically anticoagulated at 24 hours. Additionally, there's 5 times higher risk of bleeding with unfractionated heparin. And perhaps one of the drivers of overuse is the fear that the patient may go for a procedure in the future. And it's important to note that only 5%, around 5% of patients with acute PE have an advanced procedure like a cardiac or a catheter-directed thrombolysis or thrombectomy.
That's awesome. Thank you. Dropping wisdom on all of us. And so thank you both for joining us on the show. Hope to have you back again in the future. And thank you all for tuning in to Quality this week.
Thanks, Arjun. That was a lot of fun.